Hi, good evening, everybody. This is the last session for the year. And here we have with me Dr. Suhail Suresh, who's also my colleague from Sunway. He's a consultant orthopedic surgeon and does robotic surgery. So without further ado, we invite Dr. Suhail to give the talk.
Hi everyone, good evening. Today I'm honored to speak to you about how do I approach knee osteoarthritis. I'm sure many of you see such patients. So before I go ahead, just to make an announcement, Friday is a public holiday for Kuala Lumpur because we won the city of KL won the football match. Okay, so those of you working in KL, Friday probably don't have to go to work. Please check your schedules.
You mean this Friday?
This Friday, the 3rd of December. Yeah.
Oh.
Yeah, this day after tomorrow. Okay, so I work in Sunway Medical Center. I'm basically an orthopedic surgeon who has got a special interest in arthroplasty or joint replacements, especially hip and knees. So today's talk, the overview would be give you some definitions, and then we'll talk a bit about causes, symptoms, signs of osteoarthritis, investigation, and last but not least, treatment options. I always like to put up this picture. This picture was taken in Heidelberg when I was doing my fellowship in Germany. It's a very interesting picture. It's a nice sculpture, huge, very tall sculpture, which shows how important a joint is to all of us. Without a joint, we cannot move. So if you go back to our old medical school days, we know the major function of a joint is to allow you mobility. So without a joint, mobility is going to be very, very difficult. So we want to preserve mobility as long as we are alive, because otherwise it's going to be very difficult for us and for our caregivers. So what's the prevalence of osteoarthritis? Worldwide, there are about 7% of the whole population, which consists of about 500 million people. Women are disproportionately affected more. The ratio is 3 females to 1 male. And in the greater Kuala Lumpur, greater KL, we have something like 30.8% of our population aged 55 years and above who are reported to have knee osteoarthritis. That means it's almost 1 in 3 of our population, especially in greater Kuala Lumpur, has about knee osteoarthritis. And I think overall in whole of Malaysia is also about the similar figure. So what's osteoarthritis? Let's look at this picture on your left-hand side of the screen. Basically, the yellow structured part is the what you call your bone, and the white structure is the cartilage. As time goes by, the cartilage thins out, and then eventually you get the subchondral bone become exposed. That's when the pain becomes more consistent and permanent. And on your right hand side, you've got a picture showing the macroscopic view of how a cartilage looks like. A cartilage is actually basically pearly white, shiny material which overlies the bone. And basically, in the first stage, you have cartilage fibrillation. At this stage, when you do an X-ray, you're not going to see anything. Unless you do an MRI, you're going to find slight thinning of the cartilage, but otherwise, on an X-ray, you're never going to pick up anything at all. And then, as it becomes more progressive, you sometimes can pick up a bit of subchondral bone sclerosis, which is a white line beneath the joint surface. And then eventually the cartilage thins out, and then to the point where it becomes irregular, and you begin to see marginal osteophytes in the sides of the bone. And eventually you begin to see cysts. Now, this cyst formation is actually a very interesting characteristic because it first starts with a microfracture of the cartilage, and then because of the pressure in the cartilage, the joint fluid enters the subchondral bone, and eventually it forms a cyst. So sometimes the cyst can be quite large, and the cyst sometimes can be picked up on an X-ray. So who gets them, where, and why? As I said earlier on, the females more often than male, where basically osteoarthritis can affect any joint, but predominantly weight-bearing joints. Knee by far more common than hip, and then comes ankle. Of course, sometimes it can happen in your wrist, and also in the cervical spine. Why there are many causes for osteoarthritis, depending on whether they are primary or secondary. So primary osteoarthritis, as we all know, there's no other cause. Basically, age-wise, because of age progression, wear and tear, somebody can get osteoarthritis. But there's the other group, which is the secondary osteoarthritis, which is quite common as well, especially post-trauma. Rarely you get osteoarthritis if you have a mid-shaft femur fracture or a mid-tibia fracture. But if someone gets a fracture around the joint or periarticular fractures, then yes, they are more predisposed to getting osteoarthritis. And the earliest is actually about anywhere up to about 5 years if the joint surface is not well reconstructed. Infection is another culprit. Sometimes patients end up with septic arthritis. You treat them for septic arthritis and then they go away. Many years later, they come back because there is chondrolysis or cartilage degeneration as a damage as a result of the infection. Then, of course, there are other causes like psoriasis, gout, rheumatoid arthritis. Now, majority of the male patients that I see who have osteoarthritis are usually as a result of hyperuricemia leading to gouty arthritis. And rheumatoid arthritis is more predominant in females. This is an X-ray of someone who has got osteoarthritis. Basically, you can see, appreciate the distal interphalangeal joints eroded, the joint space narrowed, and in this picture, in the thumb, you can even see the proximal interphalangeal joint subluxating. So basically, the cartilage wears off, the joint becomes unstable, they form nodules in the joints, and then they present with deformities of the joints in the fingers. So symptoms, majority of the patients who come to you in the early phase usually is pain, and then occasionally, sometimes when there's an acute bout, there is swelling, and then well, of course in the chronic stage they present to us with deformities, either a varus or valgus deformity. Now, majority of the time, if it is primary osteoarthritis, is a varus knee, whereas if it is either post-traumatic or rheumatoid arthritis, they're usually a valgus knee. So of course, occasionally you get patients coming and telling you, something like how this picture goes. This cartoon shows it makes a creaking, mopping sound every time I get in and out of the car. So he actually went to see the mechanic and thinking that it was his car door, but in real fact, it was his knee that actually was making the creaking sound. So sometimes patient comes to us and say that, my partner says that, my joint keeps creaking every time I move or get out or get out or get onto a chair or get out of a chair. So yeah, so crepitus creaking sound is also another presentation that we occasionally find. Signs, deformities, reduced joint motion, they get limitation of range of motion because the capsule becomes tight, the muscles become contracted because of pain and they're not moving. Grating sensation, this rough feeling when you put your hands on top of the patella, and of course joint line tenderness, and occasionally, like I mentioned just now, swelling if there is effusion. This is another nice picture of a lady who has got bilateral valgus knee. The right knee is more pronounced compared to the left knee. But you can also appreciate, apart from her knee, you can see that her feet, her ankle, and her toes are all inwards because she's trying to compensate to stabilize her knee. So she's got secondary deformities of her toes and her ankle. So by this stage, when they come to see us for knee osteoarthritis, they also already have some amount of ankle osteoarthritis. So that's why it's very important to catch them early and treat them early rather than allowing them to become much delay. And in these kind of cases, you can imagine how bad the spine will also be because of trying to compensate for the unequal weight distribution that they've had. So investigations generally for osteoarthritis, a radiology investigation is more than sufficient to make the diagnosis and after a proper clinical assessment. But occasionally you want to rule out rheumatoid arthritis, you want to rule out gout, you want to rule out any other form of secondary causes, then probably a blood investigation would be necessary. So these are some X-rays which allow us to, sorry, let me just go back one. Yeah, so the top left-hand side, you can see this picture. Basically, the top is an X-ray and the bottom is a diagrammatic representation of that X-ray, which allows us to easily understand what the X-ray is all about. So that's the distal end of the femur, that's the proximal end of the tibia. And you can see on the lateral side, the joint space between the two white lines is reasonably well preserved, but on the medial side, you can see there's significant narrowing. And on the next picture, you can hardly, barely make out the joint line. So it's a very, very thin line. So you can imagine this is almost like an ankylosed knee already, which is like almost like a fused knee. And the other picture on the side, you can see on the sides, there's a bone spur, and this black cavity is actually the cyst, the subchondral cyst that has become so huge. And also you've got cysts on the distal femur as well. This picture is the X-ray of the lady earlier on. So you can see her knees are valgus. There's hardly any joint space. The joint line is unequal. One is higher than the other. Even the other knee has got no joint space left. Whereas this picture is a varus knee, where the joint space is completely gone. The medial compartment is so badly, the cartilage is so badly eroded, so much so that now she's beginning to lose bone instead of only losing cartilage. And this makes the surgery a bit more challenging, difficult, and also the cost of the implant for such late stages is even much more expensive, almost double than the normal primary knee replacement implants. So that is another reason why somebody should be motivated to have the surgery done much earlier. Now this, once you've seen all those bad ones, then you can try and appreciate the normal X-ray. So basically, when we order a knee X-ray, ideally it should be a AP and lateral. Possibly a standing view is good, because if you use a standing view, you can actually gauge the thickness of the cartilage. So the distance between the two white lines, the two ends of the bone, which represents the cartilage thickness, has to be around 6 to 8 millimeters in normal cases. And you're not supposed to see any uneven surfaces in the sides of the bone. They should be very clean. They shouldn't have any osteophytes. So that's how a new, what do you call, a normal X-ray supposed to look like. So, a bit on the treatment, which is, we usually speak about non-pharmacological, but by the time the patient actually arrives at my suite for consultation, they were already probably done most of this stuff. And these are some of the good things that as a general practitioner, or if you, when you're seeing a patient, or if you're advising your family members, these are good things to follow. Of course, weight reduction, when you reduce body weight, the load on the knee is lesser. Every kilogram that the patient loses in body weight, there's a 4 kilogram reduction in the load on the knee joint. So modifying activity, do the things that they can do rather than do the things that they cannot do and then injure themselves or wear off their knees even worse. Use walking aids whenever necessary. Regular exercises to maintain the elasticity of the tendons and ligaments, and to make sure there's no contracture. Occasionally, you can wear a brace or a splint when you are playing a game or doing certain kind of sports or doing some activities. So the good old phrase about walk rather than run, sit rather than stand, it still holds true. It means if a patient can walk, then it's better for them to walk rather than do a running exercise. And if they can afford to sit, they probably had better for them to sit than stand when doing a certain thing. This is for I must what do you call explain further that this is basically for patients who have osteoarthritis, not for patients who are normal. Okay, so The other thing when we speak about brace, this is an interesting brace that some of the patients like to use. So basically the alignment in this first picture shows that the patient has got a varus knee. So the patient can get such braces where there is a force on the sides to make sure that the knee is well corrected so that it doesn't become too varus and they can move around. So this lady, one of my old patients, we fitted her with one and then she came back and she said, no, I want another one. For me, I thought it was a bit more cumbersome for me to wear this and walk around, but she was very, very comfortable. When she wore this, she didn't have to take painkillers and her knees were much straight and she was going around using this for a very long time. Yeah, so these are one of the few things that you can do, and they can have reasonable range of motion, and when they're resting, you can take it off. Yeah, but some patients prefer to do this. And this is also an alternative for patients who cannot undergo surgery for any particular reason. Pharmacological options, basically whatever we are doing is we are giving them pain relief. It extends from the NSAIDs, opioids, and COX-2 inhibitors. Now, I tend to be a bit careful with NSAIDs in this group because we know this is going to be a chronic problem. And so basically the NSAIDs or the COX-2s, I use them as a rescue medication, and I keep them on either paracetamol or opioids in the background. So either one or two tablets once or twice a day in terms of paracetamol, and then if need be opioids. Occasionally, when it's really very, very painful, they can use an NSAID because sometimes some of them start off with having osteoarthritis as early as 50, and they go on for many, many years. When by the time they come and see you for a knee replacement, maybe when they are 60, I always tease them and say that they probably barbecued their kidney already by then, so it increases the risk of surgery and the complications. So the other options available are disease-modifying drugs like glucosamine sulfate and chondroitin, and there's also a combination that you can use, either glucosamine sulfate plus chondroitin. The other important pharmacological option that we have is intra-articular injections. Basically, intra-articular injections, there are three types: steroids, PRPs, and platelet-rich products, and also hyaluronic acid. I generally tend to use more hyaluronic acid and occasionally steroids. If a patient comes in, young patient, we usually try and avoid the steroids unless they have got a very severe bout of inflammatory arthritis. The knee is very swollen, very painful. You feel that there's significant synovium inflammation, then probably a steroid will help together, either independently or together with a combination of a hyaluronic acid. PRPs, yes, quite a lot of people use PRPs. There are various studies, but I think the general consensus is if you use PRPs in the early phase, especially after the injection, there's an inflammatory reaction, so the patient tends to have a bit more knee pain for the first, at least up to a week. And then after a week, they tend to do better than the hyaluronic acid. But at the end, after beyond 6 months, both the hyaluronic acid patients and the PRP patients do about the same. There's not much, there's no clinical statistical significance between the difference of PRP and hyaluronic acid. Apart from that, the other thing that stops me from using PRPs is the insurance companies don't cover PRPs for most of my for almost all my patients. So unless the patients are self-paying, but then patients must understand what they're getting into. So if you're using PRP injections, ideally you should prescribe them strong pain relief medications, because they're going to go back home and then they're going to have quite significant knee pain, and they probably think that they've got septic arthritis by the time they come back and see you. So must be very, very careful as compared to hyaluronic acid. This was a study which we carried out some years back in UKM. I think it was in 2004, 2005. Basically, patients, this is the number of patients and this is the number of weeks after an intra-articular injection. And basically, we do the Lacquerson score to see the functional ability of the patient. So from 0 to 2 weeks, there's a significant number of patients who say, yeah, they've improved. And static, well, somewhere in the middle, and the worst ones are down, become lesser. So obviously, when they start, they actually got more pain. Within 2 to 8 weeks, there's still quite a lot of people who actually have improvement. And then eventually 8 weeks down up to about 24 weeks, which is up to 6 months, the efficacy of the injection drops a bit. And then either they become static, but they don't become terribly bad. But beyond 9 months to a year, they tend to have pain back because the injections last them anywhere up to 9 months to a year. But occasionally patients do come back and tell you, you know, I've had this injection, it lasted me about 2 to 3 years. That's probably because they had the injection when they're at a very early stage rather than at late stage. You know, at grade 3, grade 4, rarely they last more than a year. In grade 4, even maybe up to 2 to 3 months. So generally in my practice, if I give them an intra-articular injection and they come back after 2 weeks, within 2 months or 3 months, I tell them that, look, there's no point having another second intra-articular injection because you're probably not going to do well. So you're better off having surgery rather than spending your money having intra-articular injections, especially if you use a high molecular weight intra-articular injection. So management algorithm, so lifestyle modifications, a bit of acetaminophen, NSAIDs, COX-2s, steroid injections, opioids, and then the next step is hyaluronic acid injections. And then if that fails, then you probably need to refer the patient for surgical intervention. And in the good old days, we only talk about knee replacement for osteoarthritis. But now there's a bigger move towards cartilage preservation surgery. Some of these procedures have been around for the longest time, but never been popularized. But now there's a re-emergence of popularizing what you call cartilage preservation surgery, especially for the younger patients, because we know that if you do a knee replacement for someone who is young, there's a lifespan for these implants, anywhere within 20 to 30 years, depending on how young they are and how active they are. So the other options available are arthroscopic debridement. We'll go ahead and explain a little bit more. Chondrocyte transplantation, hyalofast, and osteotomy. Arthroscopic debridement basically is washout. If you wash out all the debris, the synovial fluid, which contains all the chemical mediators, take away some of the osteophytes, address the meniscus, degenerative meniscus, which is torn. Osteochondral allografts. So now basically this picture shows you a picture of how we take, let's look at this top picture. So someone has got damaged cartilage in this area. So what we do is we take the non-articular surface cartilage and then we put it into the damaged area, and it looks like this. So basically what you're doing is like applying Mosaic on the floor. So orthopedic surgeons from becoming carpenters now become tile layers already. So this is the other thing that you can do. So you put all this. So basically the periphery part where the cartilage is not articulating, it's already not necessary. So you can take that and then you can implant it in this damaged area. So and then eventually as years go by, they act as just like a graft basically. So you have an option of either allograft or an autograft. So this is a picture of one of the cases that we did. So basically we took out the cartilage from the non-articular surface and then cleaned up the center. And if you can appreciate, this is the non-articular surface in the side. That's the middle groove. So you planted the cartilage on the groove in the center. And with this, the patient can go on for years. So the other name for this procedure is called mosaicoplasty. Of course, sometimes you can't find good autograft, then you can probably take allograft from a cadaver and also plant it in.
Sorry, Suhail. So when you take the autograft, right, the area that you have taken it from, it will regenerate back?
No, that area will be covered by fibrocartilage. And that area is, because it's a non-contact area, so it doesn't cause any
see.
problem.
So basically, you're taking somewhere that is non-contact to put
Ah,
at the contact area. So
yes,
it does not regenerate back now.
it would not regenerate in that
Yes,
area. Okay, so this is another example of a patient who has got, basically this one is osteochondral allograft. So basically the patient has got a deformity, and then we correct the deformity by doing an osteotomy. We take out a small wedge, correct it, put the
Wow.
plate in, and then that part of the cartilage which is damaged, we slice it and remove it, and then we use a graft from an allograft from a cadaveric donor, and then we put that piece back and then put a screw. So then the allograft will incorporate onto this patient's bone, and then eventually that will be his host bone. Similar to this picture as well, where the degenerated cartilage is removed, like a small tile piece, and then we take the cartilage from the cadaver in a nice rightfully measured space, and then we put it back inside here, and then we put some what do you call small screws to keep it in place. So that's another technique. So basically you don't have to, you address, but this, the caveat to all this is the lesions must be very small, like 1 by 1 cm or 1.5 by 1.5 cm, nothing more than that. But if you've got generalized osteoarthritis, obviously you cannot do
When
such.
you take from the cadaver, they sell it like that.
Yeah, so we can when we order the cadaver, we can tell them that we want a distal femur, an articulating surface. So they will sell it to us at that price, and whatever we want. So if you want a tendon, they'll sell us a tendon. If you want a ligament, they'll sell you a ligament.
Really?
Yeah, so you can have parts, different parts of the body utilized for different things.
Like spare parts.
Yes, something like spare parts. Yeah, something like spare
And
parts.
where do they come
For the
from?
sake of science, for the sake of science.
Where do they usually come from? This
Well, we have our own tissue bank. The most commonest place we get our tissues is from the tissue bank in there's a very well set up tissue bank in Kuban Korean Hospital, HUSM. We have another bone bank in HKL. These are two places that we can get. Of course, sometimes when we don't have our own donors to give, or the bank do not have enough of such products, then we can get them from abroad. I think some of them come from US. There are a couple of companies from US which export allografts to Malaysia. So there are a few companies
very interesting.
with the approval from the Ministry of Health. Of course, these are tested there. The donors are tested, and then eventually after the window period, they are tested again, and then there are certificates issued for all these allografts before they are brought into the country. So yeah, that's available. So you can get allografts from different parts of the body. Okay, so the other thing is autologous chondrocyte implantation. So basically, this is a picture of, not very clear, but this is a picture of a patient with osteoarthritis of the knee. If you can appreciate, that's the femoral condyle, that's the other condyle. The patella is somewhere around here. So basically we are seeing from lateral, and you can see a huge crater on this side, and all these are osteophytes. So basically this is the damaged area. So what we did is we actually take the patient's cartilage, and then we grow the cartilage outside in a bank, and then after about 6 weeks, we bring back the cartilage, and then what we do is we clear that damaged area, and then cover this covering is actually part of the periosteum. So we take periosteum from outside on the femur side, and then we stitch it onto the bone, and then from a space here we inject back the cartilage inside. So eventually the periosteum will incorporate with the cartilage, and then the patient will have his or her own cartilage. Again, these procedures can be done only for small lesions, not for everybody. This is another thing that's been popularized recently now. It's called hyalofast implantation. So basically, this is a picture of a patient who has got bad osteoarthritis in one of the femoral condyles. So what we do is we do an arthroscopy, and then what we call is at the end of the arthroscopy, we drain out all the joint fluid in the water, and then we make small holes on the subchondral bone to bring in blood and neovascularization from the subchondral bone, and then we patch this with a gel-like substance called Hyalofast, and then we cover it with a periosteum. And sometimes we could even add some bone marrow onto this, and that will also allow the cartilage to grow. This has also been very, very promising. The only downside with such procedures is once it's done, the patient may not be able to weight bear for some time. We are looking at anywhere within 4 to 6 months. You can't weight bear on that knee until the cartilage grows. So that's something that not very many patients can accept, not being able to weight bear on the knee for 4 to 6 months. But then again, if it's a young patient, these are the options that they have as compared to going for a knee replacement, because no one in the right mind will do a knee replacement for somebody who is less than 50, 55 years old. So these are the options for younger patients. Now, high tibial osteotomy is basically to correct the malalignment or the misalignment of someone. So basically, this patient has got a varus knee. We can cut some parts of the bone and then cut and then realign the thing and put some staples to make the knee straight. So this is another procedure without having to go for a knee replacement. Of course, knee replacement surgery has been around for the longest time. There are many different types of implant that are available today. I just want to highlight this top implant, which has got basically the femoral condyle and the tibial base plate, and has got these 2 rods. These are usually done for revision cases with this rod. So if you see someone's X-ray with a rod going with a knee replacement implant plus a rod inside, it's highly likely that it was actually a revision knee replacement, not a primary knee replacement. So we also have gender-specific knees. So we realize that sometimes some of our female patients have got very narrow trapezoidal bone as compared to the male patients. So the traditional implants may be a bit too broad for them, and this will probably impinge onto their soft tissue. So now we have a female version for some of the patients. So at the end, before we implant the final implant, we do a trial, and then we decide whether we want to put the broad one or the narrow one, depending on the patient size. Like you see, if you could appreciate this picture on the bottom, if I put this implant in, this is the trial implant, you can see how much it's overhanging. You can see the shadow. So this is going to impinge on the soft tissue, and that's not going to be very comfortable. And the patients may complain of knee pain even despite having the knee replacement surgery. Then we also have custom-made implants. We have patients who are dwarf, patients who are not, who have got very abnormal morphometry of their bones, and in this kind of patients, we are looking at needing very specific custom-made implants. So we do a CT scan, and then we send out the CT scan pictures together with their 3D reconstruction to the manufacturers, and the manufacturers will make the implants based on that.
Why not MRI? Why CT scan?
CT scan is very good for bone. MRI gives you a lot of soft tissue.
I see.
Tissue,
okay.
Yeah. Okay, I think overshot. Okay. So now the other implants that we have for knee replacements are implants specific for the compartment that is which is damaged. So in the good old days, anybody who has a knee very bad knee osteoarthritis, if they have failed medical management, we put them up for a total knee replacement. Today, we don't do that. We try very hard to preserve the ligaments, preserve the soft tissue, and change whatever that is necessary to be changed. So for example, in this patient on your far left, you see that's the femoral condyle. You just basically see one small dot there. That's the patella, which is been opened up. And on the top picture, you can see how bad the patella looks like. So the femur looks pretty pristine, whereas the patella looks bad. The cartilage is degenerated quite significantly. So for this patient, if you go and do a total knee replacement, it's actually overkill. So what we do is we do a patellofemoral joint replacement. So basically, the button goes on the patella, and then this metal component goes in the center where the trochlea is, and then you've got an articulating surface. So the ACL, PCL ligaments, medial, lateral, collateral ligaments are all preserved. So it's very much like a natural knee. Apart from the pain that you've had from the patient would have had from the patellofemoral or anterior knee pain, now the patient wouldn't have had the anterior knee pain anymore, yet very stable knee and very quick recovery, very small incision. They can go back home within 2 or 3 days. They don't have to stay in the hospital very long. And their post-op rehab is also very, very simple. They can even use a walking stick rather than use a walking frame. Biopoly is another new thing that we use. So someone has got, again, this is the trochlear area. You can appreciate where that's the medial and lateral femoral condyle, that's the center groove. So if that part is damaged, we can use a punch to remove that area, and the punch has got a sizer. You can measure the size, and then you can pick out from the shelf the polyethylene, which is at the same size as the punch, and then you can replace just that particular portion. Similarly, you can do that for the patella as well. But you can't do it for the trochlea and the patella together. You can only do it for one surface. So again, quick recovery, ligaments all balanced, very fast because the patient to go back home. The pain relief is also almost quite instantaneous. Okay, this is a bit more popular, unicondylar knee replacement as compared to the other things which I mentioned just now. So if you have 100 patients who have got knee osteoarthritis, maybe 10% will probably fall in the unicondylar group, whereby only one compartment, in this patient, and most of the time is the medial compartment because of the way the mechanical axis moves. So the medial compartment gets worn off very much. The lateral compartment is pristine. So we go in, we replace the medial compartment only. So this is how it looks like. The femoral component on the top, that's the polyethylene in the center and a small base plate. So the part of the cartilage in the medial side is shaved off, and then we replace it with the metal and the prosthesis. And this last picture is the surgical picture of a patient who has got a unicondylar knee replacement. Patient comes in the morning, does the surgery in the afternoon, stays for another 2 nights, and then goes back home with a walking stick, and then can start driving within a week, full recovery within 2 to 3 weeks, and the patient's back to work. So almost immediately. So very, very quick fix, very little, risks. The risk for a unicondylar as compared to a total knee replacement is almost half in everything, like deep vein thrombosis with less by 50%, infection rate less by 50%. So hospital stay and the cost is also much cheaper. So again, but must be caught early in the sense that the presentation must be quick before the entire whole knee becomes damaged. This one is a bicompartment. That means the patient has got the patellofemoral and the medial compartment. So instead of the 3 compartments, now we have got bicompartment. Not very commonly done though, but it is an option. But because by the time the patient has got 2 out of the 3 compartments needing replacement, the patient is probably better off having a total knee replacement. This is a picture of a severe total knee, severe osteoarthritis of the knee. If you can appreciate this top right picture, that's an end-on view. The patella is inverted on this side. That's where the patient's body is. This is the foot end. That's the entire femur that we are staring at. End-on, that's the lateral femoral condyle. That's the medial femoral condyle. You can imagine the medial femoral condyle has a huge crater, a huge like hole, basically. So there's nothing left there, and you can imagine patients like this still can walk around in our country. And that's the medial side of the tibia. And this is another picture of the same patient. You can appreciate how deep this crater is. But yeah, they can walk. Why? Sometimes fright, sometimes not confident, sometimes ill-informed, sometimes basically they don't have the means to do it. And many of the times it's usually ill-informed patients. People tell them that, doing a knee replacement won't give you good results. You're probably worse off than worse off having a knee replacement than without. So with that, they walk around with this until they cannot walk, and then they find their quality of life is so badly affected, and then they come to us. Okay, so one of the few things that we've been doing before is computer-aided surgery. So why? The question is why all this technology? Why can't we just use the implants that we already have? So over the years, there's a lot of improvement that has been done on the implants. So the question is why would you want to improve implants which are already good? So basically, we want to try and stretch the number of years these implants can last. The conventional implants usually last a patient anywhere up to about 20 years. After that, a lot of minor improvements have been made to stretch the implant longevity. So one is material. We have changed materials from, we have changed materials from cobalt chromium to titanium to what we call ceramic. We have changed the polyethylene from high density polyethylene to cross-linked polyethylene. All that has pushed up things. But then what we also have in our hands is when we implant all these implants onto patients, we use jigs. So jigs are based on general population size and morphometry and angles. So what people came up with is with computer-aided surgery. Basically, the computer aids you in placing the implant in the right position. So if your implants are placed in the right position, and if you don't have outliers, they will last you even longer. How long? Maybe 25 years or so. So we carried out the first robotic surgery in 2005, me and my team in UKM. That's some 15, 16 years ago. And ever since that, we have moved on to other forms of surgery. So basically, when you say computer-aided surgery, basically it means we do the X-rays, and the X-rays are fed to the computer, and the computer decides what angles these implants should be put in this patient so that you get the best, best results. So the pre-operative planning is given to us, the size of the implant that needs to be put in, what angles the bone has to be cut, so that you can place the implants precisely. So no more, it takes away a lot of eyeballing. So implant components with greater accuracy, reduce blood loss because we don't open up the medullary canal, reduce incidence of transient hypoxia and confusion, reduce surgical and radiological outliers. So sometimes, and in this way, you know where your implant is going. So better surgical outcome increases the implant longevity. So then we have now migrated to robotic assisted knee replacement. My first robotic knee replacement was in September last year. So why has it been slow? Why haven't we embarked on a bigger scale? First of all, whenever technology comes in, we want to make sure that technology has stood its time and the results are very good. So especially for joint replacement surgeries, if you do not have at least 3 to 5 years follow-up, it's impossible to jump into the bandwagon and take on the technology. So the technology is here, and the other thing is, of course, the cost of these robots. They're pretty expensive. Most of these robots cost anywhere within 3 to 5 million ringgit per robot, and there are also a lot of consumables to be utilized. But of course, there's always this question whether the price that you're paying balances out the outcome that you have. And the economic studies have all proven that there's shorter hospital stay, better outcome, less pain, less bleeding, less incidence of fat embolism from such technology. So definitely there is an advantage in using such technology. So these robotic assisted surgeries are surgeon-centered. They are assisted surgeries. The robot doesn't do the surgery. The robot stands as an assistant to the surgeon. They're accurate and they are reproducible. So once you get your angles right, I can do it. I can pass it to Betty to do it. I can pass it to anybody else who is trained to use the robots, and they will be able to get the same or similar accurate reproducible results. And they're very, very efficient. So basically, a patient walks into the suite, sees me, and then I send the patient down for an X-ray. In that X-ray, there is this calibrating balls that they put on the patient's limb when they do the X-rays, and then those X-rays are now fed onto the computer. The computer will do the morphometry marking of the femur, the angles. We'll look at the condyle size, the flexion, the extension, the ligament, how far the bones are in between them, and then come up with a 3D what you call configuration, and it also includes the cartilage in its measurement. So basically, this is how the robot arm looks like. The robot arm brings this cutting jig onto the bone. So basically, I have to make the incision, clear the soft tissue, expose the bone, and then press the buttons for the robot to bring its arm right to the bone. So once it brings this jig onto the bone, then I put the pins on, and then I use a saw to cut through this small space. So basically, my position to cut now is fixed, and I can't make an error. So if I do a recut of 2 millimeters, exactly 2 millimeters will actually come out. So that's how precise the cuts are. So you cannot. It's there's very little room for error when you do such things. This is a picture of how when we were doing our surgery. This is at Sunway Medical Center. So that's the operating side. That's me. I've got an assistant. That's the implant vendor, and that's the scrub tech, and that's our anesthetist. And this is the robot camera. So the camera is viewing where the bones are. There are trackers on the bone, which is picked up by the camera, and then it's connected to the robot, which is on my left. So then the robot arm is brought into the field to do the cuts. Yeah, okay, I think the video doesn't work, sorry. So, okay, so new technology. So new technology is very attractive and have constantly evolved. They expand the possibilities and the surgical indications. They improve our knowledge for knee biomechanics. They also try to restore native knee function. So basically, that's the function of this robots. That's the advantage of using them. So with them, you at the end of the day, you try and bring them back to the native knee alignment for your patients. They promise better surgical outcome. There's an increased implant longevity, and of course, all this translates at the end of the day to increase in patient satisfaction. So these are some of the few pictures I'm going to show you about how the knee replacement looks like. This is one of the patients which I operated about, I think maybe past 3 weeks or so. A lady with bilateral knee varus knee, severe pain, unable to walk. You can imagine there's no cartilage left at all on this side. The other side, there's also osteophytes already. So we decided to do the knee replacement. You can see how accurate and how straight and how beautiful the knee is now. And you can only appreciate how comfortable this patient is. And after she had done this, she was already asking when I can get my other knee done. And she has been having this knee for the longest time and suffering for the past 5-6 years. So sometimes it's just getting them past that stumbling block to explain for them to understand that this will give them good results. This is how the pre-op planning in the robot looks like. So sometimes the patient with 15 degrees of valgus knee, and we can actually correct it up to about 3 degrees. This is a picture of another lady who was referred to me by another orthopedic colleague. Said that this lady's got severe bilateral valgus knee, and said that maybe the robotics could help her achieve a much straighter knee. So we said, yeah, fine. We went ahead and did a bilateral knee replacement for her, and look how straight she is now. So she's not only gotten her knee straight, she's gained length, height, and she's a very, very happy patient. In fact, I think day 2, day 3, she was already saying that I've never been able to walk so comfortably, and I think I would like to go back home. So yeah, this is how grateful patients feel, when you give them from this to this. You can imagine how happy they are. Now, most of us use now high flex knee replacement. So allows the patient to flex the knee up to about 150, 147, 150, 55 degrees. So that in a way helps a lot of our Asian patients because some of them want to still go back to kneeling, squatting. Some of them want to go back to being able to pray. So yeah, so this is another example of a patient who had surgery and then she used what you call a high flex knee implant, and you can see how much she can flex. And she's come back for another knee surgery after some time. And this is another patient who is very happy after a knee replacement. He's able to sit cross-legged, I'm sure, and by this he can actually also be able to pray in his regular way. So this is another patient who's got bilateral severe knee varus deformity, and you can also appreciate that she's had her CABG bypass done for her heart. And so these are the kind of patients that we see with multiple comorbids. And that's how her knee looked like. Imagine the cavity, the space, there's hardly anything left. The bone, not only the bone is gone, but also the cartilage is gone, the bone is even gone. So in this kind of patients, we need to have a stem down, we needed to put bone graft, that's why there's screws and the rest of the stuff to make them more stable. This is another lady with bilateral knee osteoarthritis. Can you imagine this knee walking around? It's locked. She's just basically locked.
Looking at it is already painful.
Exactly. So she's just created a crater and she's locked herself. One condyle has just gone in and locked into that crater. And so when we dig so in this kind of patients where there's a lot of bone loss, there's a lot of ligament instability, obviously you need to use a more constrained implant, what we call as a revision implant for these kind of patients. So I hope this works.
Suhail?
Yeah.
Okay.
One second. I just want to see whether this works or not. Okay, it's not working. It's actually a very a nice video of showing you how a knee replacement surgery animated. So yeah, before I end, so yesterday's dream is today's memory. So basically, we dreamt about doing navigated surgery. We are past that now, 16 years. Now we're on to robotic surgery. So the future is here. This is what we call as cutting edge surgery, and this is all at the end of the day for the betterment of our patients. Yeah, with that, thank you.
Wow, it's been a very interesting lecture. I'm very enlightened actually. It makes cardiology look like Jurassic kind of practice. Okay, we do have some questions. Okay, and Serena asks, can the osteochondral allograft be applied in hip joint as well?
Yes. Yes and no. Depends on what's actually happened to the hip. I'm going to give you an example. If a patient has got osteonecrosis.
Okay. Hold on. Sorry. Do you mind not sharing, stopping your share so that I can?
Oh yeah, I can stop. I can stop. Yeah, that'll be good.
I also forgot. Okay. Thank you.
Okay. So basically, if in patients who have got osteonecrosis of the femoral neck or femoral head, in those kind of patients, yes, we can introduce a what you call allograft. But for osteoarthritis of the hip, allografts don't work very well, simply because the weight in the hip joint simply cannot, the allografts cannot take the what you call the weight, and they will eventually give way. And we know that the hip is is not a biplanar, what you call joint. It is actually a 360. So you need to have ligaments all around it in order to make sure that the hip joint is well functioning. So yeah, only part, not the whole hip joint.
Okay. On follow up this, where you do the allograft and your grafting, right? It is meant for patients with small amount of damages, right? How do you assess these damages?
Okay. So basically, when they come to see us, they say, "Oh no, I've got knee pain." So when you do the X-ray, you realize that they've got osteoarthritis. But when we look at the X-ray, we find that you suspect they have got osteoarthritis based on clinical history and signs. But when you do an X-ray, you don't find the joint space very badly damaged.
Yeah.
So there's still quite a bit of bone joint space, but yet their pain doesn't correspond to the X-rays. So then you realize that, okay, look, there's something else that's going on. Either they've got a meniscus tear, they've got a ligament sprain, or they've got a hole in the cartilage, which when we do an MRI, we'll be able to pick that up.
I see.
So
from
then
MRI.
MRI, and then following the MRI, what we usually put up the patient for is an arthroscopic procedure.
I see.
In that arthroscopic procedure, it acts as a diagnostic as well as also a treatment procedure. So that's where that's how we do it.
So the arthroscopic procedure would then immediately you may or may not do something for them.
True. So if we already suspect things enough and we have got all the things on board, like if you want to do an allograft procedure, you must have the allograft available, and you need to order the allograft because storage is very important. So so it's important to bring the allograft and keep the allograft. So for that purpose, usually if it's an allograft procedure, it would be a secondary procedure rather than a primary procedure. But things like hyalofast, autografts, and all that, we can do it on the spot. If we have the consent and we have primed the patient, we can always go ahead and do. But the only, like I said, the only problem with this is the patient must be ready to do it, because the post-op care is very, very important. The rehab will take time. The patient will not be able to wait there for a while. And young patients are the ones who need these procedures, and the young ones are the ones who are impatient, who want to be able to wait there, want to go back to sports, want to go back to work. So it can be a bit of a challenge. So they must be very well informed. They must be very well counseled in order for them to undergo such procedures.
Now, total knee replacement, you said, can last for a long time, right?
Yes, the current implants can last the patient 25 to 30 years. So there's a caveat to all this. Now, basically, when we say 25, 30 years, it basically depends on in vitro. We put this prosthesis and then we cycle the prosthesis, and the prosthesis can go through, like, say, 25 million cycles. So if I finish the 25 million cycles in 10 years, obviously I'm going to wear off the polyethylene much earlier.
I see.
So for somebody who is young, anywhere within 50, 55 and below, if they are still wage earners, they are working actively, they may utilize the knee more than somebody who is 65, 70 years old. So that is one of the reasons why in the good old days, people tend to propose a patient for a knee replacement when they are 65, 70 years old. But what we realize over the years is our implants have gotten better, the longevity is better. And we also realize that patients go through a lot in their early years when they are productive, when they can be productive, looking after their knee and unable to do enough work. I'll give you an example. A 45, 48 years old lady who is working, who is actively working, earning a living, looking after a family, has got bad osteoarthritis in the knee. You tell her that, don't walk too much, don't sit too much, don't do exercises, take your painkillers and rest, and then wait until you are 60 years old to have your knee replacement done. So 12 years of her life is gone. So who's going to give her back the 12 years? At the same time, we don't want to put a knee replacement when she is 40 years old, because we know the longevity is not good. So we stretch, but we somewhere in the middle, we cut our losses and we say, okay, look, we give her a good quality of life and let her go ahead. Because otherwise she's going to also take a lot of painkillers, and by the time she comes to us when she's 60, probably her kidneys are buggered, and her risks are 3 or 4 times her earlier risk of doing the surgery.
Okay, we still have some questions. Ashwin asked whether there's any prophylaxis for osteoarthritis for young people.
Yeah, not so much of basically when let's put it this way. When we move, there will be friction, and when there is friction, you will eventually wear off your cartilage. The question is whether you wear off your cartilage when you're 45, 50, 55, 60, or 80 or 90 years old. So that's for that reason, the older the population, the higher the incidence of osteoarthritis. So how can we look after your knee or our knee to prevent it from getting bad osteoarthritis at an early age? So one, of course, is you must not abuse your knee, must look after your knee. You must make sure if you've got ligament injuries, you've got meniscus injuries, treat them early so that you get a stable knee. Make sure your muscles around your knee, your quadriceps, your hamstrings are strong to be able to support your knee. When you're doing a specific sports, make sure your attire is right, your shoes are right. If you're doing something very aggressive, make sure you have got protective gear around your knee so that you don't damage your knee. Now, moving forward, of course, things like weight reduction, we spoke about it just now. And if your knee is painful, seek treatment early. The things like what you call glucosamine and chondroitin and the rest of the stuff, basically only what we call delay the process of your osteoarthritis from getting worse. They do not. There's nothing that can reverse the process of osteoarthritis. As of now, there's no magic medication to tell me that, if I have got grade 2 osteoarthritis and if I take this tablet routinely every day without fail for the next 10 years, my osteoarthritis is going to reverse to grade 1. None. Full stop. Basically, what some of us feel, some surgeons feel is that if you have got osteoarthritis, your ultimate treatment is a total knee replacement. The question is when you're going to have your total knee replacement.
So Feroz asked whether is there any role in stem cell therapy for grade 1 and grade 2 symptomatic osteoarthritis?
Okay, good question.
Yeah, because you didn't mention at all, right? Stem cell.
Now, the reason why I didn't mention stem cell is because so far there's a lot of research which is being done for stem cell. We don't see very many promising results being published.
I see.
So that becomes a difficult statement to defend. A lot of people claim, yes, that the stem cells have done tremendous work. Our regular question to everybody is, imagine if stem cell was the answer to osteoarthritis of the knee. Imagine if stem cell was the answer to all the osteoarthritis of the knee. Then many patients would have stopped doing knee replacements. And in many countries, people wouldn't be spending so much of money trying to improve the technology of a knee replacement. So there are still a lot of patients, and all the money would have gone down in providing patients stem cell. So that's not actually happening yet. So the jury is still out there. And for the past 10 years or more, there's a lot of stem cell research which has been done. In fact, I think even today there's an ongoing recruitment of studies of stem cell in UKM, which is going on now again. So there are so many studies. There are a lot of papers being produced, but convincing 100% that if I do stem cell, my knees are going to get better is still questionable.
Can I ask, when we talk about stem cell therapy, it is a direct injection into the joint, right?
Yes.
It's not a infusion or anything like that.
Yeah, so there are different types of stem cell. The mesenchymal stem cell, you can take stem cell from the adipose tissue, you can take stem cells from bone marrow, and then you process them and then you inject them into the joint. It's not given IV, but it is injected into the knee joint so that it can home in the knee joint. Sometimes it's coupled with procedures like arthroscopic debridement, and sometimes if the patient has got a lax ligament or a torn ligament, they repair the ligament and then they do the stem cell injection. Yeah, so it's coupled together.
So on the same note about prevention or prophylaxis, Jilinki asked whether avocado soy saponified. Is there any comment on osteoarthritis?
Oh, sorry, what was that again?
Okay, if you look at the comment section, At the bottom, there is ASU, avocado soya
unsaponified.
Yes.
So it's soya, but now it's avocado soya. Yeah, so I mean, all this, basically the answer to it is I don't know the answer. I mean, people have proposed various types of diet, milk.
Oh, I see. It is a diet.
Yeah, it's a diet for knee osteoarthritis, but I mean, this basically comes under the group of supplements, and we know it's difficult to prove or disprove them. Just like everything else in medicine, as long as you don't cause any danger to the patient, I think you can try, and if it works for you, fine. But if you're going to spend a couple of $1 million buying just that milk, then I think probably not the wise choice to do.
Is there any reason why women gets it more?
Very interesting question. I've been asked this time and again. So basically, there are two peak incidences, where female patients are more exposed to osteoarthritis. At least this is the hypothesis. Okay. One, because of the regulation of menstrual cycle in a patient, the females tend to have ligaments which are a bit more lax compared to men. And we all know if you measure the Q angle in females, is far bigger than the men. A Q angle is basically the angle drawn from the anterior sphenoid spine to the patella, and the patella downwards to the tibial tuberosity. So basically, the gliding angle of the patella. Now, with that also, we get lots of ligament injuries in female athletes. More ACL tears, more collateral ligament tears, more ankle ligament tears, because the ligaments are lax, and hence the joints are not strong enough to sustain when they're doing vigorous activity. So that makes the knee joint a bit unstable on and off, and exposed to injuries. That is one group. The second group is when female patients undergo menopause. All of a sudden there's a sudden increase in body weight, and sometimes it becomes
That's
very
not true.
not in all of them, but there's a significant. I mean, if you see across all females, there's a sudden increase in body weight, especially in the group after menopause.
I see.
So that also, I mean, basically this is the hypothesis. Okay, so in that group again, they do the sudden increase in body weight tends to also increase the load in the knee. But having said that, I've seen a lot of females who are menopause who still keep themselves very well, very fit. You know, some of them are still jumping around, doing a lot of activities, sports activities, and they can maintain themselves very well. So yeah, so but these are two main reasons why people.
Is pregnancy one of the reasons for this lax,
there's always a possibility. I mean, it's never been studied, but there's always a possibility that the pregnancy again contributes to that.
Okay, we've done very well. I really think that you were excellent, and I
Thank
think
you.
that yeah.
Can I just address one more thing? I think Serena said.
Oh yes,
I think she
Serena.
meant piascadine, though it is a group A evidence. I eat avocado and soybean. Yes, I mean, piascadine is another supplement that one can take for osteoarthritis of the knee. Though it works in a different way compared to what you call glucosamine, but yes, piascadine. There are studies to show that piascadine does help patients. But I just want to say this: whether you're on any form of supplement, how I look at it is, if somebody is on glucosamine for 6 weeks, a minimum of 6 weeks to 2 months, and if it has not made any changes to them, then it's highly unlikely that they are going to benefit from taking this glucosamine for the next 3 years. So because sometimes when you see patients, you ask them, how long have you been on glucosamine? They say, oh, I've been on glucosamine forever. And has it made any difference? No, it has never. So that is another question altogether. Yeah. So how I usually look at it is, if I see a patient and the patient is never been on glucosamine, then and if they're in early stage of the disease, so you put them on glucosamine for a good 4 to 6 weeks. And I tell them not to expect it to be a magic drug because it's not a painkiller. Then and don't throw it off within the next first 2 weeks. At first 2 weeks, you expect maybe 10-20% difference. Up to 4 weeks, maybe about 30 to 40% difference. Of course, there is this question whether it's a placebo effect or not, but only the patients will be able to answer if they stop it or not after they stop it. So at 4 weeks, when I see them back and they tell me, say, look, it has not made any difference whatsoever, then I tell them, look, it's probably you're not going to benefit from it because the general population, maybe about 70% of the patients, 50 to 70% may feel good. Another 30 to 50% say it doesn't help them. So if they don't feel well and the knee is still troubling them, then we escalate to the next step, which is probably the injection.
So this product that Serena is talking about, how do you pronounce it? Piescladine. Is it it comes in a...
It comes in a capsule. It comes in a capsule.
I see. And all this, how do they work actually? Is it does it really fill up a space over the joint? Like,
no, okay, so basically what these supplements do is they increase the viscosity of the fluid inside the knee.
Oh, it does.
Fluid, yeah. One, I mean that's how it's meant to work. So it increases the viscosity. By increasing the viscosity, it reduces the friction, and by reducing the friction, the wear and tear is lesser. Hence, the cartilage can last longer. That's why it's never been meant to reverse the pathology. It doesn't reverse the pathology. So yeah, so instead of losing, let's say, example, 0.1 millimeter cartilage a year, so now you lose 0.05 mils of cartilage a year. So it doesn't stop, but it reduces the wear, reduces the
I imagine that the pain must be really, really severe because a lot of people are acceptable to knee replacement. And they're...
True, but again, sometimes, I mean, in my practice, I see sometimes patients, by the time patient comes to see me, they've already probably been with their GPs, and the GPs have been doing a fantastic job looking after them for sometimes 5-10 years. It comes a point where they cannot stand the pain, or their quality of life becomes bad.
Yeah.
And I always tell this to patients. I mean, if your life is determined by how much your knee can do, not how much your heart can do, not how much your eyesight can do, not how much your wallet can do for you, but if your knee determines whether you can go to your son's house, whether you can drive your car, whether you can climb the stairs, or you can walk in the mall or go to the shopping center or go to the mosque for a prayer or something. So if your knee determines that, that means your quality of life is bad, and that is determined by your knee, and that means you need to fix your knee.
The most amazing thing, one of the most amazing patients I've seen is, I did a pre-op assessment for this knee replacement patient who was 86 years old. She had bilateral knee replacement. And 2 weeks later, she's riding her motorbike in Pulau Ketam.
Exactly. So again, age is not the determinant factor of whether the patient can or cannot have surgery. What's important is the physical ability, not the chronological age. I think just my oldest patient, hip replacement patients can become very, very old. Maybe I've even seen patients up to 99, even 100 years old going for a hip replacement. But for a knee replacement, I think my oldest patient was about 89 years old. In fact, last week I did another consultant's mom who was 84, 85 years old.
Yeah.
But she's so thankful because for her, the reason why she came to do the knee replacement is she's 84, 85, but she stays alone and she drives a car to the bank herself, to the market herself.
Exactly. A lot of times it's because they are not mobile.
Exactly. Yeah. So the mobility.
Yeah.
Yep.
Okay, we will stop here.
All right.
I would like to thank you, and I would like to wish everybody a very good new year ahead. We are really, today is the last month, and you know, I've done this almost every week for the last 1 year, and this is the last session. I'm so happy actually. I'm so proud of myself, and I'm also so happy that I don't have any more session. I think I will go shopping from.
You should.
Yeah, and then next week next year I have to rethink what to do. I mean, I'm going to continue. Okay, I'm going to stop recording now.